afternoon, ladies and gentlemen. Welcome to today's webinar entitled the OIG Work Plan. If you'd like to submit a question to the presenter during the webinar, please use the questions feature on the Nord dashboard. Our presenter will address submitted questions in today's webinar. At this time, it is my pleasure to introduce Devine, Senior Director of Revenue Cycle at BESLER. The floor is all yours.
Tom, thank you very much. I just want to make sure that you can hear me okay, as you were a little muffled and difficult to understand. Can you hear me okay?
Yes, ma'am.
All right, perfect. So good afternoon. I want to thank everyone for joining this afternoon. As Tom mentioned, I will be talking about the OIG Work Plan today. I have a lot to cover, but I promise to not take more than an hour of your time this afternoon. Just to quickly run through an agenda and what I'm going to talk about. We're going to talk about the 2020 updates to the OIG Work Plan. Certainly go over some of the recently added audits. We'll mention some of the completed reviews. We'll take a look at some of the important items that remain open. There are certainly a bunch of items specific to the COVID-19. And then I'm going to talk a little bit about the items that are specific to the transfer DRG, something that's very near and dear to my heart. And then finally, I'll talk about some of the Medicare Advantage specific audits and items. So from an objectives perspective, I hope to accomplish a review of the important updates on the work plan, highlight the intent of the new items listed, provide action steps to move forward, understand what the audit means to you, what you should be doing to avoid Medicare takebacks from an OIG audit. So before I really dive into some of the updates, I thought that it would be a great place to kind of step back and just re-review the overall intent of the OIG work plan. I know that everyone's very familiar with the OIG and their work plan, but I think it would be nice to just quickly review the purpose and the mission. So the OIG operates by providing independent and objective oversight that promotes economy, efficiency, and effectiveness in the programs and operations of health and human services. Just a quick refresher, reminder that although we think it's specific to CMS and more specifically mostly Medicare, the OIG is certainly reviewing a lot more than just CMS. They review a whole bunch of other agencies in their work plan. The mission is to protect the integrity of HHS programs and the health and welfare of the people served by those programs through a nationwide network of audits, investigations, and evaluations, as well as outreach, compliance, and educational activities. And so really, they are there to protect and help and even make things better for all that is served and providers, beneficiaries, and CMS. So with the updates, prior to June of 2017, the work plan was reviewed and updated once or twice a year. Currently, the work plan is now reviewed and updated on a monthly basis. But if you spend a lot of time looking at the OIG work plan, as I do, you'll really notice that it's updated more frequently than that. Sometimes there's 2 updates in 1 month, and sometimes there's even 3 in 1 month. June was a busy month. There were a lot of things added due to COVID, especially as it relates to the nursing homes. Beginning in January of 2020, completed work plan items stay on the active work plan for just 1 month, and then they move to the archive tab. So if you go in, you're looking for a specific audit that they were working on and don't see it on the active plan, make sure that you take a look at the archive, because there is a completely separate tab for that. And then recently completed reports can be found on OIG's What's New page. And if you look there today, you would see plenty of reports that have already been issued as it relates to COVID-19. When I was looking at them, I happened to notice that Palmetto was mentioned in a lot of reports out there. And again, just as the OIG isn't specific to CMS, the reports that are issued are also not specific to CMS. There are other agency reports out there as well. So as you scan, if you're just looking for CMS ones, make sure that you're aware of that. Many items on the work plan are to review data to capture intelligence and an understanding of Medicare patient. It also allows Medicare to determine use and overuse of certain drugs or tests, and it can form opinion on provider practices. And that really is, those are what's focused on the protection and the health and welfare of the people that's mentioned in the mission. It can lead to positive changes in patient care or reimbursement. DRG changes are quite often the results of the data mining that is done by the OIG. And it's not always on recruitment or fraud and abuse, although unfortunately from a provider perspective, that's always what we remember that the OIG brings to the table. So to jump into the 2020 work plan updates, there are currently 121 active items on the work plan for CMS as of June, of the June update. There are 33 items that were added in 2020, and a good chunk of them are, in fact, specific to the COVID-19 items. There are 14 items expected to be reported on this year. That doesn't mean that they'll be closed, but the reports will be issued this year. There are 47 items that are partially completed and 9 fully completed in 2020. Just a quick rundown of the items open by year. There are 11 from 2016, 9 from 2017, 20 from 2018, 35 from 2019, and 46 from 2020. So we're going to go ahead and jump into some of the 2020 additions to the work plan. One of the big ones was the advanced care planning services, the compliance with Medicare requirements. So Medicare pays providers additional for face-to-face care planning to discuss the care planning and focus on the discharge and the patient outcomes. And they're going to be auditing those to be sure providers are meeting those face-to-face requirements and they're not being overpaid. This was just added in 2020 as an audit item, but with the onset of COVID-19 and the blanket waiver, much of this advanced care planning services was waived in that. So if they are going to audit this, it would obviously have to be for claims that were submitted for that face-to-face prior to the March 27 or the PHE. The next addition I wanted to mention was the assessing inpatient hospital billing for Medicare beneficiaries. And this has been out there for a long time. It's been out there since 2016, and it really is kind of a two-part that they've put it on. So in 2016, they found that hospitals were billed $114 billion to Medicare for inpatient stays. And CMS has identified problems with upcoding or optimizing reimbursement or maximizing reimbursement. And they developed a two-part study. So they're taking a look at from 2016, and then they went ahead and they audited claims from 2018. And then what they did next is they looked at the two areas, 216 and 218, and any hospitals that had a significant increase in their case index, those are going to be the targeted hospitals. The next item I wanted to mention was the data brief and the measuring of characteristics of hospitals with wage indexes in the bottom quartile for the fiscal year 2020 inpatient prospective payment system. Hospitals have been arguing for quite some time now that it is unfair to have the 4-year window on the wage index because they can't increase compensation due to that. So CMS and the OIG are gathering data to determine the validity of that and to see if that does make sense. And you know, this is something that the providers have been arguing for, and hopefully the OIG and CMS are listening. Medicare covers cost for any new hospitals for the first 2 years. And then after the first 2 years, it then switches to the capital cost is contained within the DRG through the IPPS payment. So now they're going to be auditing the capital payments that are made to new hospitals, and they're looking to determine if there's a cost savings if they start right out of the gate with it being paid based on the IPPS DRG amount. And unfortunately, this audit is probably not going to be in favor of the providers. And this next item that was added is certainly targeted as a cost savings to CMS. So they're going to be reviewing the Medicare DRG window policy. And they're going to take a look at claims in 2018 that if they expanded that DRG window from 2 days to 4 days, and they included additional services that were provided to common owners, that they were wondering if they would potentially save money. And as part of that, they're going to be interviewing CMS staff to consider maybe there's an alternative payment model that they would be able to include more services within that full DRG payment. And again, that's going to be on services in 2018. As I mentioned earlier, there were 9 items that were completed so far in 2020. They are working on hopefully completing 47 additional, but right now there's 9. So one of the ones that was completed is every year, this is on the work plan and marked as completed. Federal law requires independent evaluations of the MACs to ensure that their information security program are up to regulation as it relates to the federal law. And then then the OIG must report back to Congress on the assessment with the scope and the sufficiency of the security of the MACs. And this is done annually, and this is to protect the beneficiaries and all the PHI that the MACs have in their possession. So there's a bunch of, as I mentioned, there's a bunch of open items that providers should certainly be aware of and probably visiting on an annual basis themselves until they are closed, if they will ever be closed. And some of these open items, some of them are profitable to CMS. It certainly is a cost savings, or they're able to get overpayments back into them. Some of them are telling from the perspective of that it provides on patient care or provider patterns. And then there's certainly some open items that are a little bit of both. They certainly provide that cost savings as well as provide some intel on either provider patterns or patient care. So from a profitable perspective on some of the open items that they have, and this is a big one, CMS Medicare overpayment recoveries. So the OIG does an audit, and then CMS has 6 months to collect those audit findings. And from 10/2014 to 12/2016, the OIG identified $640 million in overpayment recoveries that need to be had by CMS. And OIG has confirmed that to date, for that time period, CMS has only collected $566 million. So they still have $82 million to collect. And so they're following up on the audits that they did, making sure that CMS is getting all those recoveries back from the providers. Certainly a profitable item for OIG and CMS. Another one that is certainly more profitable than anything else. So post-hospital skilled nursing facility care provided to dually eligible beneficiaries. And this was open since March of 2019. So these are patients that are Medicare and Medicaid. Because they have that 3-day qualifying stay, they are pushing them to a Medicare level of care for that reimbursement versus the Medicaid, which is much lower than what Medicare would pay for a skilled level. And they're finding that the level of care was inappropriately increased for reimbursement. So they're auditing for appropriate level of care, and then they're going to recoup all the money where the patients were actually non-skilled. And let's not forget that with COVID-19 and the blanket waiver, those 3 days are waived as well. So there's no requirement for a 3-day stay in order for a patient to be covered by Medicare for skilled care. So you just want to make sure that if that patient's going for skilled care, that they are actually needing the required level of care that is indicated from a skilled level, from a rehab perspective or from a nursing care perspective. You just want to make sure you can support that medical necessity. Another one that's been open since 2016 and unfortunately is focused on skilled nursing facility reimbursement as well. And it's very similar. SNFs are required to assess their patients with a minimum data set to determine what the payment category is or that RUG category is for the patient. And it is significantly different from the lowest RUG to the highest RUG. So the OIG is going to continue to find SNFs that are billing for higher levels of therapy than were provided or were reasonably necessary. And again, there's a focus on level of care and medical necessity. And if you are billing for a RUG category and the patient isn't receiving 20 hours of therapy a week, that would be a fraudulent claim that you would be billing to Medicare. And so this is an audit, and it remains open since 16. The next one I wanted to mention is as it relates to the EHR incentive payments to hospitals. This has been on since 2017. From January 2011 through December 31, 2016, CMS made $14.6 billion in EHR incentive payments to providers. That is a large sum of money. And CMS admittedly faces great obstacles in overseeing the Medicare EHR incentive program, both, the effectiveness of it and the calculation of it. It is really difficult to oversee the meaningful use of the certified EHR technology. It's difficult. And the real focus is on the interoperability to improve health outcomes, and the ability for computer systems to exchange and make use of information. And again, CMS is struggling with that, so there is overpayment as it relates to those. And the overpayments are expected to be about 20%, or almost $3 billion of overpayments to providers. And this due to the inaccuracy of the calculation of the incentive payment. We're now going to get into some of the telling, the ones that are more focused on, trying to understand some of the patterns in either provider or patient care. So the potential abuse and neglect of Medicare beneficiaries, this has been on since 2018. And this is focused on the neglect of the elders and disabled persons that would come in for inpatient or outpatient care. And they're determining, they're going to take a look at the quality of care and the reporting of and investigation of potential abuse or neglect at group homes, nursing homes, and skilled nursing homes. And they're looking to determine the frequency of the abuse and where the abuse is coming from. Is it in fact coming from specific nursing homes or skilled nursing facilities? And then another item that's telling and has been around for quite a while. And actually, this was an audit that started 10 years ago, and now they're going in and doing an update to follow up on some of the things that were out there in 2009 to see if things are getting better. But Studies show that 27% of Medicare beneficiaries experience adverse events or temporary harm events while hospitalized. Falls, infections, pressure ulcers that cause the patient to be in the hospital longer. So they're taking the data that they learned in 2009 and they are going to pull the data from a diagnosis perspective and procedure perspective, and then they're going to compare it to data that they pull in 2019, and they're going to compare year over year to determine if there's been reductions or increases in harm to the patients. And then we're going to look at a bunch of a little bit of both, a little bit of telling and a little bit of cost savings. The first one I'm going to talk about is the review of hospice compliance with Medicare requirements. So when a beneficiary elects hospice care, the hospice agency assumes the responsibility for medical care related to the beneficiary's terminal illness. And it is a nice sum of money that they receive to care for that patient. But there are, as any other agencies do, there are conditions of participation requirements. And the hospices have those as well, and that they had to adhere to in order to receive payments from Medicare. So what the OIG is going to do is they're going to review the hospice medical records and billing documentation to determine whether the hospice services and payments were made in accordance with Medicare requirements. And if they did not meet the conditions of participation, they will be retracting that money from the hospice for the care of those patients on hospice. A little bit of both and targeted at hospice care. So when a patient is at home receiving hospice care, they are, a nurse is required to go out there, a registered nurse must go out there every 14 days to see the patient. And so the audit is going to determine whether these on-site visits are happening within 14 days of one another. And they're making sure that it's happening. So there is care for that patient, as well as, are they getting paid for something they shouldn't? And then I do have to mention that with the blanket waiver, this too was waived. There is no longer that 14-day face-to-face or on-site that this could be done from a telemed perspective. So the telemed has to happen then the 14 days and the documentation has to be there, but there is not that on-site with the patient. So we're going to jump into some of the work plans added in 2020 specific to COVID-19. So obviously all these items were added in 2020, and they were added probably from the end of February to June. And there is, the focus is certainly to gather intelligence regarding treatment, comorbidities, and what patients are at high risk and why they might be at high risk. And although there has been a payment increase for COVID-19 treatment, the audits really are not focused on the reimbursement. Any inpatient that's discharged with a diagnosis of COVID, there is a 20% increase in your DRG. So the first one that was added to the work plan as it relates to COVID is really done to understand hospital utilization during COVID-19. They're going to use Medicare claims data, and they're going to review it and analyze the effects of COVID-19 on hospitalized Medicare patients and the resources needed to care for them. They're going to review utilization of the treatments provided and paid for by Medicare for the COVID-19, just to determine selected localities that have known outbreaks, probably New York and New Jersey. And they're going to look at length of stay and some of the resources that were consumed. What type of treatments did they consume? What type of medications were they provided? What type of therapies did they receive? So they have some intelligence around and better understanding of the utilization of services for COVID-19 patients. The next one, and opioid alone is a big focus of the work plan, but as it relates to COVID-19, it's specific. The NIH has come out and said that patients with an opioid disorder are at a much higher risk of COVID-19 and are getting hit hard due to the respiratory issues of it. So they're using that data brief to provide information on the utilization among beneficiaries enrolled in Medicare Part D, as well with the COVID-19 diagnosis. Just, again, a better understanding of people that contract COVID and what are some of the complications. And then this is just yet another statistic around the opioid use, and they're looking at potentially that patients that doctor shop, and they want to identify prescribers who ordered opioids in large numbers for these beneficiaries. Just a bunch of statistics that they have in order to better understand and do better in the future. Again, there's quite a big concern that due to COVID-19, people are afraid to go and seek services. So they're not going to see their doctors, and they're not getting their prescriptions refilled, and they're not going out for treatments from their physicians that they need. And so they're going ahead and they're going to study utilization of drugs for medication-assisted treatment is low, and they think it's due to the fact that they're afraid to access their care due to COVID-19. So they're just looking into that from an information perspective. And they want to make sure that people are getting the therapies that they need, and they're not just using the medication-assisted treatment. Again, want to make sure patients are getting what they need due to COVID. And this is just another focus of impact of not receiving services, and patients are with an opioid use disorder. They're declining, and they're just, or what kind of characteristics do they have in common? A lot of studies being done around that. And this item was just added in June of 2020. We all know that there is a big focus from CMS on COVID in the nursing homes. And so this one, CMS added a requirement that nursing homes now report COVID-19 data to CMS on a weekly basis. And they also have to report it to state and local health departments. So basically what the OIG is doing, they are auditing or reporting to CMS on providers reporting to CMS. So the OIG is going to make sure that the information is getting reported to the nursing homes, and they want to make sure that it's complete, accurate, and reliable. So again, they're going to be reporting to CMS on providers reporting to CMS. As part of the COVID-19 data gathering, this one too was just added not that long ago. They want to look at nursing homes meeting the challenges presented by COVID-19. COVID-19 pandemic has created unprecedented challenges for nursing homes. And this is really nationwide, and they are doing a two-part study on nursing homes examined with how COVID-19 pandemic has affected nursing homes. So from the two-part perspective, they are looking at my page won't turn. There it goes. Sorry about that. So the first part, they're going to look at nursing homes that were hardest hit by the pandemic. And as a second part, they're going to look at nursing homes that did a great job at mitigating the effects of COVID-19 on residents and staff. And then they're going to develop strategies around that. And CMS has recently come out with strategies around the nursing homes, and reporting and not letting any visitors in, whether essential or non-essential. And there were 5 pieces to it, and focused on the containment of infection control and revisiting infection control from a national perspective. And that was just released, I want to say 2 weeks ago or so. And that was the result of some of the audits that the OIG did. This one is a little interesting. So this is the trend analysis of Medicare laboratory billing for potential fraud and abuse with COVID-19 add-on tests. So from an add-on perspective, they can do 3 or 4 additional tests from that one single specimen. And with the COVID-19, there has been a high demand on diagnostic laboratory testing to determine whether the individual has the virus. And then if they don't have the virus, then they're doing a bunch of add-ons to rule stuff out. And the interesting part about this is you don't need a physician order to get the test. And then on top of it all, you don't need a physician to diagnose. That was part of the waiver, that the patient can be diagnosed from the lab test versus a physician's conclusion. So you not only have the relaxation of the physician ordering it, but you also have the relaxation of the physician drawing a conclusion. So they are really focused on the fraudulent billing of unnecessary add-on testing. And so we all know that there has been a big push to Medicare telehealth, all kinds of telehealth, not just by Medicare, but by all providers during the COVID-19 pandemic. And CMS is exploring whether telehealth flexibilities should be extended. So it's obviously going to be real focused on the effectiveness of it and the use of it. And it's a 2-part study. So the first review will examine the extent telehealth services are being used by Medicare beneficiaries, and then how the use compares to the use of the same services delivered face-to-face. Is it as effective as a face-to-face or not? And they're going to determine what types of providers are using the telehealth services. And then the second part of it is they're going to determine integrity risk as it relates to Medicare telehealth. And this is kind of where the reimbursement comes in. Are the telehealth being appropriately used and reimbursed? Is there the proper documentation in it to support the effectiveness of the telehealth visit? And then next, I wanted to talk about the items in the work plan that are focused on the transfer DRG. Me, for sure. So they closed one and opened one that are almost similar. So the one that they closed, it reads very similar to the one that they opened again. Follow-up review on inpatient claims subject to the post-acute transfer policy. This is marked complete, and reports are being issued this year. Either you have received a report or you will. And this was done because CMS realized their edits are not 100%. And it was the OIG recommended that they get these right. And it was known that the edits in the system are only 85% right. So, 85% of the time, it'll capture when a patient received post-acute care services, but it wasn't reflected on the claim. It'll edit out for a C7272 error, and then you'll fix the claim. But again, there was a chance for a 15% error rate on that. So, hospitals were marking the patient as a to home when really they received services from a home health agency or from a skilled nursing facility, and they were paying. So it was focused on getting those corrected. So OIG recommended that the CMS correct those common working file edicts, and they have done so. And to be honest with you, we are finding that Palmetto has overcorrected, and we're seeing some rejections of C7272, and there is no post-acute service provided. Maybe a RAP was opened, but the service was never provided, and we're seeing rejections as it relates to that. So we're ending up having to speak with a provider rep and get them fixed anyway. So then they're going to do a follow-up audit, which will determine whether the CMS corrected the CWF edits or not. And that's what was then opened back on the work plan. So it was added in March of 2020, just as they closed the other the transfer audit, and it is basically the same thing. It is a review of hospitals that received the full DRG versus the per diem, but they were in fact found to have been transferred to a post-acute transfer provider. And then the other thing that they're looking to do is they're going to be looking at patients, Medicare patients, that they were discharged, they received the per diem payment, and then Medicaid ended up picking up the post-acute care, and they're calling that, they're looking at some cost shifting, and it's going to be focused on that as well. So they're going to be looking at those patients that received the full DRG and shouldn't have, as well as looking at patients that were discharged and Medicaid ended up picking up the post-acute care. The one other transfer rule that remains open, and this is, it's been open since 2018, and it is the use of condition codes. Those patients that were discharged to home care, and they did have home care, but either it was not within 3 days, so you get a condition code 43, or the home care was not related, and it was a condition code 42. And so they're looking at reviewing that, and hospitals are responsible for coding the claim correctly, whether they knew or not. And so Medicare is going to be looking specifically at that, and they want to make sure that if hospitals have a condition code 42 or 43 on there, you are then entitled to the full DRG, and they're reviewing for the use of those two condition codes. The condition code 42 is really, really difficult. The OIG likes to data mine, and condition code 42 is not intended to be a one-to-one lineup. It is a medical record review, so they're doing a lot less of that. The condition code 43, that's a little easier because they can tell when the patient actually did receive that service, because they have that available from a data perspective. Another item as it relates to the transfer rule is claims with outliers. It was opened in 2018, and as we know, transfer rule reduces the payment, but the outliers can result in payments that are higher than if it would have been paid at a non-transfer case. So they're digging into it to make sure that the calculation of the outlier is appropriate as it relates to the DISH and the IME and the DRG. So just going to review those, because they found that outlier payments have been overpaid and are not calculated correctly, because it negates the reduction in the per diem amount. So even if they can't figure out what the outliers, there might be a change, and if it is an outlier, then it's not impacted by the rule. Then finally, I'm going to talk a little bit about the Medicare Advantage work plan items. So CMS has always said, they're not to get involved with the MA plans unless care is impacted. The other time they will get involved is if they feel that they are paying too much money to the MA plans inappropriately. So the first one that was added in 2020 was Medicare Advantage organization's collection of ordering provider identifiers. So this, it was added in May of 2020, and its focus was on DME, laboratory tests, and home health. CMS did not require MA plans to submit MPI for ordering providers. So there was no way for the OIG or CMS to track patterns of the providers. So OIG recommended that they require the MPI submission on ordering physicians as they do for their traditional plans. So the OIG is now going in and auditing to see how many providers comply with that request, and they're monitoring ordering providers with identifying fraud and abuse. And without that MPI, it's very difficult for them to do that. So there's going to be monitoring those to see if they are actually following what OIG said in submitting the MPIs, and then track the providers for fraud and abuse as it relates to home health services, laboratory, and DME. So CMS pays a risk-adjusted payment to Medicare Advantage, and the OIG added an audit of it in February of 2020, and so CMS risk adjusts the monthly payments based on beneficiaries' demographic information and clinical diagnosis from the prior year to pay MA plans more for beneficiaries with higher expected coverage due to a higher expected treatment. So they do this based on diagnoses of the patients, and that's how they receive that higher risk based on their demographic and their diagnoses. So CMS does not monitor or require services to support that higher reimbursement. So they can have the diagnoses, but that does not mean CMS doesn't care if you're providing more services to that patient. So now they're doing a study that is going to see, we gave you high risk adjusted payments, but I'm not seeing additional services. So they're going to be auditing for that to make sure that if you submit these diags and you receive a risk adjusted payment for your Medicare beneficiaries, I want to see that you are providing more services, and that's what the focus is going to be on. And there's three open issues as it relates to the Medicare Advantage and the risk-adjusted payments that CMS makes to them, and they're all focused on making sure that CMS is not overpaying the MA plans. The one other item that I wanted to bring to your attention that is an open item, and I think is everybody is well aware of and equally frustrated on, the inappropriate denial of services and payment in Medicare Advantage. So this item was opened in 2019 and remains open. And it's always been a concern of the capitated payment model. It's, there is arguably an incentive to inappropriately deny access to or reimbursement for healthcare services so that you can increase your profitability. You're receiving money and you're not paying for services. Unfortunately, we're all familiar with this, and it has been happening for a long time now. And, again, it's focused on attempt to increase profits for managed care plans. So what the OIG is going to do is they're going to conduct medical record reviews to determine the extent to which beneficiaries and providers were denied pre-authorization or payment for medically necessary services covered by Medicare. So they'll do a chart review, and if it looks like those patients should have been covered as an inpatient stay and paid, or they should have had that pre-auth for that knee replacement, they are going to be working with the MA plans and trying to attempt to get those paid. And to the extent possible, determine the reasons for any inappropriate denials and the types of services involved. And again, CMS does not get involved unless patient care is impacted. And it certainly is impacted with these types of denials. And certainly providers are impacted. So just wanted to do a quick wrap up of things that we talked about and think about maybe some next steps. So just as a quick recap of everything we talked about, the OIG is in place to protect CMS providers and beneficiaries. It provides intelligence to better in the future. It has amazing data at their fingertips that they can work with and analyze and form opinions about. It gives insight into patient care and provider reimbursement. The OIG Work Plan is updated at least monthly, and there's items that are added and deleted on a regular basis. Just some things to consider. Highly suggest reviewing the OIG Work Plan regularly. Check for new additions, check completed items, review the reports that are there on the What's New page, and then look at how your facility measures up to what you're reading in reports on specific providers. Always encourage you to initiate internal audits based on new items added, and revisit items that remain open to ensure compliance. There's a reason that it remains open since 2016. So for auditing services, make sure, face-to-face advanced care planning meets requirements, even though right now it doesn't, it's waived because of COVID. Continue to monitor for coding optimization and not maximization, that when they compare your provider from 2016 to 2018, there isn't a huge increase without reason to your case mix index. So that would cause you to be a target. Ensure outpatient services are included in the inpatient claim based on CMS regulations. And if you are found to have any overpayments, make sure you return them. Some things to think about from a COVID-19 perspective. You want to review your lab tests and add-ons for medical necessity. Make sure there isn't an over ordering or use billing for the COVID-19 and the add-ons. And then review your telemedicine notes and outcomes and make sure that they are, the notes are strong and there's positive outcomes. For transfer, you want to perform a retrospective review on accounts impacted by the transfer rule. You want to audit for underpayments and overpayments. You want to review outlier payments. And if you identify any overpayments, make sure that they are returned. For Medicare Advantage, ensure Medicare Advantage claims have ordering providers information so you're getting that MPI on the claim. It's actually better for you and better for OIG and CMS. You want to look at audit your risk-adjusted payments for proper diagnoses and services. If you are receiving risk-adjusted payments, make sure that your patients are receiving those services needed, and fight for service coverage. Questions? And just BESLER performs both underpayments and overpayments to ensure the discharge status is correct and make sure the OIG does not find the overpayments. We have collected $2.5 billion in underpayments and typically find 1 to 2% of Medicare discharges that are in fact overpaid. BESLER performs reviews for MA claims, and our overpayment review is minimal per call fee, and results for our audits are seen within 30 days. And our review ensures your process and claims are compliant. Any questions?
Mary, we had a question. Do you know what time period the OIG will be working next to the transfer DRG items?
They have worked 2016 through 2018. So next would be claims from 2019. If you haven't received your report from them for 2016 through 18, they will get to you. But the next up is 2019.
Thank you. We have another question here. Is the OIG reviewing the MA claims for the transfer rule?
It is not on the work plan as of yet, so I don't believe that they will.
Mary, how does transfer DRG work when patient's home is a SNF?
So that works if the patient's home is a SNF, if they have multiple levels of care, they do have skilled beds and non-skilled beds, that would be a discharge status of code of 04 indicating intermediate care, and that would not be impacted by the rule. You would do the full DRG. If it is a all Medicaid nursing home, it would be a 64. And again, that would not be impacted by the rule.
Okay, and another question is the data being audited for the financial reporting or the patient population with COVID-19 or the hospital inventory of COVID-19 related to equipment and supplies?
It would be the claims submitted to Medicare. They would be auditing from the claims, and they are auditing it mostly from a resource consumption perspective and length of stay versus the specific patient population. It's really a data gathering. I'm not sure if I answered that correctly. I would be happy to do so, follow up with further information.
Okay, thank you, Mary. Those are the questions we have.
Great. Thank you.
At this time, this concludes our webinar. I want to thank everyone for joining. Have a great day. Thank you very much.